Good evening to everybody. We are here to make a UROwebinar in collaboration, in this case, with the European Society of Transplant Urologists. My name is Enrique Lledó. I am the chairman of the section. We have today a very interesting and exciting issue, the role of focal therapy in prostate cancer for kidney patients. For kidney transplant patients, we have to consider that kidney transplant patients is a population of very big amount of men with all the ages that suffer the same diseases as the normal population, the non-transplanted population. And also the focal therapy can be applied probably in this case more justified than in other populations. In fact, to decrease the morbidity associated with the cancer treatment, many of our colleagues are turning to focal therapy as an alternative treatment option. We rely on a lot of diagnostic issues. The multiparametric magnetic resonance imaging remains the gold standard for visualization, also during this focal therapy. But new imaging modalities such as prostate-specific membrane antigen, positron emission tomography, and contrast-enhanced ultrasound are being investigated. Additionally, several biomarkers such as the prostate cancer antigen 3, prostate health index are used together with imaging to improve the risk stratification prior to this kind of focal treatment. Lastly, there are several novel technologies such as the nanoparticles and transurethral devices that are under investigation for the use in focal therapy. In this case, as I told you all at the start of this webinar, we try to update the role of focal therapy in a very special population, the renal transplant patients. For this purpose, we have the pleasure to receive three outstanding speakers. The first is Professor Eric Barrett. He's professor in urology working at Mont-Souris Institute in France. He is one of the most important European specialists in robotic surgery for prostate cancer and also focal therapy in localized prostate cancer. Professor Martínez Salamanca, he works at Hospital Universitario Puerta de Hierro in Madrid. He's also the medical director and founder of the LIX Institute in Madrid. He is one of the most important pioneers in the application of minimally invasive techniques in prostate fusion biopsy, robotic surgery, and the application of focal therapy in prostate cancer treatment. And finally, Professor Claudio Martínez Ballesteros. He also works at Hospital Universitario Puerta de Hierro in Madrid and LIX Institute. He has performed a lot of exciting and very interesting clinical and research work in the use of cryotherapy, HIFU, and electroporation in the management of focal treatment of prostate cancer. And he has also an extensive experience in indication and interpretation and performing of prostate fusion biopsy. This is the agenda. We are going to start with the talk of Professor Barrett about the current situation of focal therapy in prostate cancer treatment. Next will be Professor Martínez Ballesteros talking about which is the best option in the setting of focal therapy. And finally, Professor Martínez Salamanca is going to talk us about the present and future options. After this, we are hopefully having some time for questions and answers. Nothing else. Professor Barrett, please go ahead, and thank you so much.
So thank you very much. I'm very happy to give a talk to you today on the current situation of focal concept in prostate cancer treatment. And I will give you some information or some update of the guidelines. I don't have any conflict of interest with this presentation. This is the agenda, so I will talk about the prostate cancer detection in general. Then I will give you some information regarding some general information regarding the management of localized prostate cancer and its complication. And of course, I will give you some details regarding the focal therapy. And finally, give you what the guidelines say regarding the focal therapy. So we know that the management of localized prostate cancer is easier and less costly than the locally advanced prostate cancer or the metastatic prostate cancer. So that is why a European organized risk stratified early detection program for prostate cancer based on the PSA testing has been developed. The risk is to overdiagnose or overtreat the patient who has a prostate cancer. We learned from the PLCO, the prostate, lung, colon, and ovarian trial, that PSA screening will increase the number of prostate cancer cases diagnosed, and especially the number of prostate cancer, the non-aggressive prostate cancer. However, the ERSPC, the European Randomized Study of Screening for Prostate Cancer, provided level 1 evidence that prostate screening leads to a relative risk reduction of 20% of prostate cancer-specific mortality after 16 years, and 30% of metastatic disease after 10 years. This is the two curves that we have here, the difference in terms of mortality in between the control group and the screening group. So the conclusion of these two papers is that PSA screenings help us to detect prostate cancer, and with this kind of screening, we have a decrease in risk of dying from prostate cancer, probably because we better manage the disease. However, you all know that when a patient is diagnosed with a prostate cancer, he has to face a difficult choice. He has only two options. The first one is the active surveillance, and the second one is the active treatment. According to the guidelines, the active surveillance is recommended for patients with low-risk prostate cancer, Gleason 6 3+3, or ISUP grade group 1, or patient with some ISUP grade group 2, Gleason 7 3+4, with less than 10% of pattern 4. For all the other patients, all the other one are candidates for active treatment, whatever the prostate volume, whatever the tumor volume, whatever the aggressiveness of the disease. And this is maybe something that we have to change. However, 3 major papers were published regarding the interest of radical treatment in prostate cancer. The first one is the Scandinavian paper, which has been published 20 years ago, comparing the watchful waiting and the surgery in patients with early stage disease. And the conclusion was that radical prostatectomy significantly reduced the disease-specific mortality, even if it doesn't change the overall mortality. Regarding the pivot study compared the prostatectomy with active surveillance, and the conclusion of this paper was that the treatment for disease progression was less frequent with surgery than with active surveillance. And the conclusion of the PROTECT study was exactly the same. We limit the risk of progression of the disease if we treat some patient, if we treat some selected prostate cancer, and especially the patient with intermediate risk prostate cancer. So it makes sense to treat these patients. However, you know that the radical treatment will generate side effects, and more specifically, urinary incontinence, erectile dysfunction, and bowel symptoms. That is why we try to develop another option, and especially in patients with comorbidity, like patients with renal transplant. So this new treatment is the focal therapy. The focal concept is based on the ablation of the index lesion. If we consider that the index lesion is the most aggressive lesion, and that lesion will drive the evolution of the prostate cancer, while destroying this one, we should be able to cure the patient. To do it, several energy sources have been experimented, and the objective of this treatment is first, of course, to, as I told you, to ablate the lesion, but it's also to limit the application of the energy sources at the level of the prostatic parenchyma, while preserving the urinary and sexual function by minimizing the damage of the surrounding tissue of the sensitive structure, and providing sufficient oncological outcomes in order to keep the results observed after the radical treatment. And we can do this with the advances of different tools, and especially with the advances in imaging. We know from the PROMISE study that MRI is a good tool to select or to select the patient for the biopsy and to detect the clinically significant tumor because of its sensitivity, its high sensitivity rate, and because of its high negative predictive value around 90%. So we know now, and it's a part of the guidelines, that the MRI is the prior exam to perform before any biopsy and before any treatment, because it will give us all the information regarding the specificity of the tumor, the location, and the staging of the tumor. We can also offer to a patient a focal therapy because of the accuracy of the biopsy. We learned from the precision study, from the MRI study, from the 4M study, that adding targeted biopsy to the systematic biopsy, it's a very important point if we want to better evaluate, better characterize the lesion. So the combination of targeted biopsy and systematic biopsy is the pre-required technique before, in order to have a good characterization of the lesion. Of course, focal therapy, and is not a standard, is not a part of the guideline. That is why we don't have any official recommendation regarding this practice. We just have expert consensus, and the expert opinion say that the indication for focal therapy, the good indication, are patients with a life expectancy over than 10 years, patient with a PSA less than 15 nanogram per milliliter, a patient with an MRI lesion PIRAT 4 to 5 without any capsular involvement, without any seminal vesicle involvement, with a concordant positive biopsy, ESUP grade group 2 or 3. And we know that it is acceptable to treat focally this kind of patient, even if they have an ESUP grade group 1 outside the treatment area. So no guidelines, but we know that the sweet spot for this treatment is probably the patient with a single lesion, ESUP grade group 2, a lesion which can be completely ablated. And the location of the lesion is also a very important point that we will see later. Does it work? Apparently, yes. And I would like to share with you this paper, this statement paper published in 2018 from the prostate cancer group of the EAU. In this paper, they did a review of the literature, and they consider that after focal therapy, around 25% of the patient will have a recurrences of the tumor, and they will have a very low impact on the continence and erectile function, less than 1% for the incontinence, urinary incontinence, and less than 5% for the erectile dysfunction. And they consider that if these results are verified, we should consider the focal therapy as a real progress in the management of prostate cancer. A recent update of this data confirmed that focal therapy has a high quality evidence that it improves the functional outcomes and minimize the side effects. However, regarding the oncological effectiveness of this treatment, we need more data, and we need more comparison, more studies comparing this treatment with the standard, which are the radical treatment as radical prostatectomy or radical irrigation. If we look at the satisfaction of the patient who underwent, who had a focal therapy, you see is this recent paper published by the UCS group that generally the patients are very satisfied of the treatment. Only 20%, less than 20% will have a regret, some regret of having receiving the focal therapy. And if you look in greater details, who is regretting to have this kind of treatment, it's usually patient who failed, patient who have functional impact after treatment, which is very uncommon. So to conclude, I would say that the focal therapy is a new treatment option, and it can be offered in selected patients, but it cannot be considered as a standard, and it is not a part of the guidelines because of the low evidence due to the lack of data. However, focal therapy can be offered to the patient within a clinical trial or prospective registry. In 2023, the guidelines say that because of the data we had collected after HIFU and cryotherapy, that this treatment, focal therapy using HIFU or cryotherapy, should be performed within the context of a prospective registry. And for all of the other energy sources, we need to include patients in a prospective trial setting, well-designed prospective trial setting. So I would conclude in saying that this treatment is a promising treatment, probably very interesting, especially in comorbid patient, in transplant patient. It could be a very nice option to offer to the patient. Also, because in case of failure, we have additional option, and we can retreat the patient using the same fashion or doing a radical treatment if needed. Thank you very much.
Thank you, Eric, for your so interesting talk. I mean, we are talking about option of treatment that could be applied both to general population of prostate cancer patients and kidney transplant patients. We have to keep in mind, as our kidney transplant guidelines say, that the prognosis of prostate cancer in renal transplant patients is completely similar to the general population. So the indications of this focal therapy could be more or less the same. I hope that we will have some time later after the presentations to talk about which are the best indications for each one of the populations, and also the advantages for this option for the kidney transplant patients. So I think that we must go ahead with the next presentation. Now, Claudio Martinez Ballesteros, please, you can go ahead, Claudio. Claudio is going to talk us about which one option of focal therapy should be chosen for each patient. This is a very exciting topic, and as far as we know, we have a lot of possibilities, and sometimes we have some problems to choose which is the best one for each patient. Let's see what we can do in the kidney transplant patients.
Okay, thank you, Enrique. Thank you, Eric. Thank you to the European guidelines and the S2 for this opportunity. Thank you also to my brother Juan Ignacio. So I'm going to talk about how we can choose the best option in terms of what type of energy must we use for each patient. So it's my point of view, is there are nothing clearly well recommended over other options, but I'm going to try to give you my point of view based on our own experience. So we all know we are living in our daily routine practice with the incorporation of the MRI and the MRI fusion biopsies. This has done that we have increased the diagnostic of the clinical significant tumors and the decreasing of the diagnostic of the clinical non-significant tumors, thus avoiding us to overtreatment in low risk and intermediate risk patients. So rates in global has been talked in the previous chat. We are talking about this surrounding 20% of urinary incontinence post-radical prostatectomy, surrounding 17% of erectile dysfunction, radical prostatectomy. So we must and we can to individualize treatment in these scenarios. I'm talking about low risk and intermediate risk prostate cancer. So how can we do? How can we individualize and turn patients to focal therapy, which has less possibility to induce harm? So we have at least eight types of energy but I have focused only in 4, which are cryotherapy, HIFU, photodynamic therapy, and irreversible electroporation, because there are in which more references are in the literature. How to choose the type of energy? Well, you have to choose the type of energy, first of all, depending on the tumor location. The tumor location, you have to be sure that you know where the tumor is, and for that, and to know is if there only exists one tumor, you must have an accurate mapping biopsy. This is, I think, one of the principal points. Also, the availability and your institution of the type of energy. Also, it is a good idea if you don't have 2 or 3 types of energy, and you're developing a focal therapy program, you may have alliate all institutions near you that can help you and help your patients with other types of energy if you don't have them. So obviously the experience of the institution and your own team, the evidence based in the bibliographic references, and especially in this population of pre or post transplant patients, patient status, performance status, and the functional expectancy of the patients. So what is the position of the focal therapy in prostate cancer treatment, at my point of view? Well, I think general treatment should match the extent of the disease and the patients. So we can position the focal therapy in 3 points in this simple scheme. If we divided patients in low risk, intermediate risk, high risk, the natural history of the disease and the relapse, and after all the metastatic. So we mainly in low risk, the main actor is active surveillance. There's no doubt for this. In the most of intermediate risk and high risk patient is radical treatment. So we can choose, and we must choose, ideal candidates for focal therapy in some cases of only some cases of low risk patients and some cases of intermediate risk patients. This is one of the points. The other point is, and it's in our guidelines, you can treat with a radical intention the prostate with HIFU or with cryotherapy. And after that, in the relapse scenario, also you can use focal therapy for salvage treatment. The most common one is relapses after radiotherapy, and you can do cryo, mainly focal. We do it focal in those patients who present a focal relapse pattern. So for active surveillance, it still is low evidence to support active surveillance in kidney transplant, but I think it's increasing. Okay, but I wonder if this is a population, this group of patients is a population for definitive therapy or a try to definitive therapy with less morbidity, in the same way that Dr. Lledó told us previously. What is the ideal candidate for focal therapy? You know, all of we know is a man with a localized intermediate risk cancer, Gleason 3+4, well seen in the MRI and well located in the mapping biopsy. You can also select some cases, only some cases of 3+3 and some 4+3 cases, and you must choose those cases are located away from critical structures, which are the urethra and the rectum. And obviously, focal therapy requires a lifelong follow-up, the same as an active surveillance, including PSA terminations, biopsy of 12 months, post-ablation, etc. So the tumor location is important. Tumor location is important, but if you want to treat the whole gland, for example, with HIFU or with cryotherapy, which is included in our guidelines, it's not important where the tumor is located. It is more important the size of the prostate, for example. But if you want to do a focal ablation, which means the treatment of the main index lesion within with a safety margin, the best advice you can choose is the à la carte model defined by the French group years ago, and it's located and it advises which type of energy must we use depending on the location of the tumor. So, following these advices, if we have a tumor in the posterior prostate, peripheral and posterior, the ideal therapy for this is the HIFU. If you don't have HIFU in the institution, or you don't have experience, or you're working in a private system and patients can afford it, you have a secondary option, which are cryoablations, photodynamic therapy, IRE, or focal laser ablation. If the tumors located in the anterior prostate, the ideal therapy for first choice is cryoablation. If you don't have it, or you don't have experience with this, the secondary options are photodynamic therapy, IRE, or focal laser ablation. And with lesions in the apex, very interesting lesions in the apex, you must not to use, if you're too close to the apex, to the rhabdoid sphincter, or very close to the bladder neck, avoid to use cryo or HIFU. First option, the ideal option is focal brachytherapy. It's very interesting, focal brachytherapy. And for secondary options, photodynamic therapy or focal laser ablation. We have some experience with IRE in the apex lesions, and we don't have had many problems, but it's not the main indication. So common elements for focal laser ablation, cryotherapy, brachytherapy, and IRE, we use the transperineal approach. For HIFU, the transrectal approach, and for photodynamic therapy, the transurethral approach. Okay, let's talk about what is about evidence with concerning to cryotherapy. We have a recent review on focal therapy published in May this year, and survival rates. If we have a look to survival rates of focal cryotherapy on all of these analyzed series, they move between, all of them are over 75% and near 90% in some of the cases, in some of the series, with a negative control biopsy, including 100% in one of the series, in the Onyx series, which is a classic one. So what about paying what? Paying how? What are the functional outcomes? Well, the functional outcomes with cryotherapy are talking about urinary incontinence between 1.6 and 3.6%, and erectile dysfunction can rise up to 40% in the series, in the WALD series, which is a very interesting one. Also, we have a meta-analysis comparing cryosurgery versus radiotherapy and surgery, published in 3 or 4 years ago, I think, and they consider this option, the cryosurgery, as an effective option for treat localized prostate cancer. So, in terms of overall survival, there are no differences, no significant differences between cryo and radiotherapy. But in terms of urinary bother, there is. Cryotherapy is worse, has worse results than radiotherapy. And by separate, if you analyze, we have to take into account that the cryosurgery group in this meta-analysis has worse than MECO risk classification and older area. Okay, so this is something to take into account. And talking about specifically the cryotherapy, if you analyze the focal ablation versus the whole-gland ablation, there are no differences in oncological outcomes, and yes, there are in the erectile function outcome, which is focal is better. So we have published our own experience very quickly, over than 250 patients. We have an 85% with negative confirmation biopsy at 2 years, and with similar oncological outcomes that other series. Concerning HIFU causes coagulative necrosis, is a thermal effect, causes also cavitation, protein denaturalization. So the limit of the HIFU is the location of the tumor. You must not treat, or you cannot treat tumors very close to the rhabdoid sphincter, especially, and not those tumors located beyond 3-4 centimeters from the rectum surface, because of it can limit the oncological effectiveness of this technique. Talking about biochemical survival, rates are okay. I think are okay. In the are near 85% in the primary focal ablation series of Alkoreyev. with a negative control biopsy, close to 95%. So this is very interesting and similar to other type of energies. Some authors referring to HIFU, some others have found higher urethral strictures, close to 36% more or less, so and a rate of acute urinary retention. So be aware of this. Be aware of big prostate with the HIFU. Photodynamic therapy. Photodynamic therapy, we don't have experience with photodynamic therapy. The experience in general is less common because you need you need an adequate room, you need many devices, it's expensive, many things. But in terms of concept, it's very interesting, I think. What about the rates of functional results? Are similar, many more or less are similar. Urinary incontinence, close to 10%, erectile dysfunction between 20 and 40% in some series. Irreversible electroporation, the fourth one. Well, we have experience with irreversible electroporation. If we have a look at the negative control biopsy in this review, most of them are over 80% of negative control biopsy, which is more or less the same with other energies. But I have to notice that maybe the infield recurrence rate with IRE is a bit higher than with other type of energies. I don't know why. Is it because the selection patients are more represented, at least on a score over 7 in these areas treated with IRE? Is it this for the technique? Is this for, I don't know why, but I think it has a bit higher rate of infield recurrence. Our experience, we begin the program in 2016 to date. This data is not published. We only have analyzed first 65 cases to 2020, and we have 79% without evidence of relapse over 24 months. Similar rates of without evidence are considering the whole series, which is near 100 patients, and we hope to try to publish it recent. So in summary, how to choose the SOPO energy, in my opinion? Well, we have to focus on the patient functional expectancy, especially in this subpopulation of patients which are older, and maybe the erectile dysfunction rates in the transplant patient because of the morbidity is a little higher than the general population. If you look in lower urinary impact, maybe point at photodynamic therapy and HIFU. If you are looking for lower erectile dysfunction impact, maybe look at IRE and photodynamic therapy. The recurrence rate in general is surrounding 20%. This is clearly improbable. We have to fight to get it down, and for this we have to continue working and to design new and well-designed trials. And very interesting is the use of the genomic and the PSMA PET in two ways. First, in the diagnostic way, in the patient selections, and to guide the biopsy, and finally in the guided ablation. We have done some cases, not many of them, but some guided ablations, based on the fusion of PSMA PET with MRI. And why not? The environment, the immune environment of a transplant patient is very special, and I think immunotherapy in combination with focal therapy in a future, in the scenario of neoadjuvant or adjuvant scenarios, in both of them, may have a role, and we may see it in some years. So this is my point of view of focal therapy these days. Thank you for the opportunity, and I hope all your questions.
Thank you so much, Claudio. So you have stated very well which are the advantages and disadvantages of each option. Now we have taken a very good global idea of the current situation of focal therapy, also about the characteristics of each option, and now we are going ahead with the current, present, and future options of focal therapy in the specific population of renal transplant patients. Juan Ignacio Martínez Salamanca is going to talk about this topic. Juan Ignacio, you can go ahead.
Thank you very much, Enrique, for to putting together this excellent webinar, and also my colleagues and friends, Dr. Martinez Ballesteros and Dr. Barret. I'm going to try to cover a little bit about the incidence of prostate cancer in kidney transplant recipients, which probably many of you know that the incidence, overall the incidence is 2 to 4 times compared with the standard population for the same age and sex. Also, there is a cumulative trend in the incidence over the time in these recipient patients. I think the risk is increasing over the years, 5 years, 15 years, and more than 50% after 25 years of the transplant. So it is something that we should monitor over the time down the road in those patients. And also the overall standardized mortality ratio is approximately 2 to 3 times higher than the standard population. I think that we need to try to figure it out why could be this, or what reasons could be under this observation. Probably many of them, it's not only one, but probably many of them reasons were suggested. The more incidence and aggressiveness of the malignancy under the influence of the immunosuppression. The immunosuppression also play a role, not only on the genesis, but also on the response on treatment, and also on the treatment selection process. The direct and specific pro-oncogenic effect of these immunosuppressive drugs also could be another reason. The presence of coexisting morbidities, the reduction on kidney function that probably could also increase this risk, this oncogenic risk. The late presentations due to the lower uptake of preventive strategy and screening, and also a less responsive to treatment, particularly with the use of immunotherapy. All these reasons were argued in the literature as an origin of this observation. And also we need to be very conscious that the number of kidney transplants are increasing over the time. This paper from Lentine show this trend, and also the life expectancy of these kidney recipient patients are also increasing. So probably the number of renal transplantation patients at risk of prostate cancer is going to be increasing over the time, and the urological community will more frequently be required to manage prostate cancer patients in such patients. This review from Giancarlo Marra, recently published some years ago, also made the same conclusion. So trying to put some take-home messages till here, we need to remember the overall cancer incidence in these patients is higher. It's the most common non-solid neoplasms in RTR, the prostate cancer, and also the absolute number of prostate cancer diagnoses is set to increase over the time for many reasons. And now try to explore a little bit the prognosis and the aggressiveness of prostate cancer in comparison of the RTR patients and the general population. These two reviews published in 2018 and both in 2018 review 41 studies, one and the other one 25, with more than 200 and 300 patients either, trying to answer this question. I think first of all we should clarify that the quality of the publication regarding prostate cancer in kidney transplants is not very good. It's not very high quality data, with almost no prospective and not even randomized data. So the conclusions from the evidence point of view are very limited. But the analyzing these two reviews that enclose many patients in both of them, here we have you can see how is the distribution of the tumors between low, intermediate, and high, very similar to the standard population, and also all the standard options frequently used to treat those patients. That include surgery, include radiotherapy, whether external or brachytherapy, and also surveillance, and also some hormonal options as a treatment. I think that we try to focus exactly on the prognosis, on the cancer-specific survival and overall survival. You can see here the data, 1 year, 3 year, 5 years. If you are focused on 5 years, for example, the recurrence, if you are treating those patients with surgery, is around 10%, and the cancer-specific survival and overall survival, I think is still very good, probably a little bit, but not a statistically significant difference with the standard population. So this is a very important message. You can see here the SEER data regarding the survival rates at 5 years in the different stages, and I think it's very similar to the ones that are published. So probably one of the main conclusions, whether those tumors try to be more aggressive in some ways, but the oncological outcomes are comparable to non-transplanted population with excellent overall survival and cancer-specific survival rates. And how and if the disease natural history is altered is still not very well understood. So we can try to think about it a little bit more in depth. What can be the treatment options in those patients, and also where are the therapeutic challenge? This is something also important to keep in mind. First of all, we need to tell that the lack of knowledge of cancer natural history of those patients, the presence of immunosuppressions, as we told before, regimen to avoid graft rejection, and also the position of the graft on the iliac fossa. All these three specific characteristics of this patient can have an impact on the way that we are going to treat them. I think anatomical are also interfere mainly with surgery, but also with radiotherapy. The kidney graft is usually placed on the pelvic cavity, very close to the prostate, which also can play a negative role on the treating of the prostate with surgery or radiation. And also, this data need to be considered when we are going to try to indicate it surgery or radiation. And also that are more driven by the immunosuppression could be the increased risk with regard to the wound healing, the increased risk also of urinary infection, the radiation nephritis, which is also increased by the radiation sensitivity in order to the kidneys, and also the role of the radiotherapy in the ureteric anastomosis structure. So I think that we have, with all this background, I think we have an option, a big option, to try to adopt focal therapy, at least for part of this patient population in this specific setting. I think the aims of focal therapy in globally all the localized prostate cancer is exactly that, to reduce urinary and sexual function outcomes, to improve, to keep the quality of life of the patient, and also, or even more important in this specific patient population, to reduce the intraoperative and the postoperative complication regarding to surgery and radiotherapy. Probably, and I try to explain this, the primary and secondary aims would be a little bit different. I think probably in the general population, we are going to be more focused on quality of life, and secondary on reduction of intraoperative and postoperative complication, because I think those patients are at less risk. But in the patient, in the RTR population, the renal transplant recipients population, probably this is going to be exactly the opposite. The primary would be to reduce the intraoperative and postoperative complication, but also trying to keep the quality of life in terms of urinary and sexual function outcomes. So with these two conditions, we are going to try to explore as a potential analysis how many patients of renal transplant recipients could be fit for a focal therapy. If we go again to the guidelines, I think the last version of this year try to position the focal therapy in patients with low risk or even intermediate risk. I think the previous speakers already defined this very well. Focal therapy within a clinical trial setting, a well-designed prospective trial, is something that you can do in your clinical practice. This is one of the main objectives that the Jupiter study is going to have, to try to take and provide more evidence in a highly prospective evidence way. And also, you can only offer focal ablative therapy within clinical trials or registries. So this is probably the perfect population to include in one of these registries and to offer focal therapy. The guidelines state also that the HIFU and the cryotherapy should be the options at least preferred for the standard treatment selection. If we back to these two reviews and we try to see how many patients are in the groups of basically intermediate risk, we can see that probably 20 to 30% of the patients previously treated with radiation or surgery would be fit, would be feasible or suitable to do focal therapy according to the AAU 2000 guidelines 2003. And also, if we are going to include some of these potentially fit patients, that for sure the main option would be active surveillance, but also we can offer them if they consider, or if we consider in the global setup of the patient to treat it focally. Also, we can add another 30 to 60% of the patients. So if you can see this data, probably around 80% of the patient could be fit or suitable to use focal therapy in this population. Also, if you take a look of this series from 2023, and you do these calculations, these two groups, the low and intermediate, could be potentially patients for focal therapy. This is a registry that includes patients from 9 institutions, all of them with prostate cancer in kidney recipient transplants. So if no significant deviation from the natural course of the prostate cancer in non-renal transplant can be demonstrated, probably organ-preserving strategies in this population should be analyzed by definition and trying to aim and trying to reduce the complications. And especially if we are trying to see that the more younger patients in comparison with the typical age of the prostate cancer onset, we are going to see in this special population, and also these early stages that probably can allow us to treat more focally and more organ-preserving strategies. This is my last slide. I think overall we can say that in this population the incidence and mortality is higher. The most common non-solid neoplasm, as we already mentioned, that they try to think about focal therapy in this patient, that there's a potential strategy to reduce complication in comparison with surgery or radiation. And also, if we try to do this potential analysis of the previous series already published, probably up to 40% with intermediate, and also adding another 30 or 40% if we treated some or part of the low-risk patients, could be suitable, could be fit for focal therapy. Thank you very much.
Thank you so much, Juan Ignacio. I think we have more or less 8 minutes for some questions. Not a lot of time, but also we have some time for 2-3 questions. I would like to encourage people who is attending the meeting to send us your questions. In the meantime, I would like to ask you all, we have to consider 2 main populations: the populations of patients before the transplant, patients who are in the waiting list, and patients who can be diagnosed on prostate cancer, treated on prostate cancer, and they have to wait sometimes until the moment they get into the waiting list again, and those patients after the transplant. According to the guidelines of the renal transplant of the EAU, the prognosis of patients treated of prostate cancer is more or less the same, comparing general population to kidney transplant patients. So do you think that we can keep on the same criteria to decide in all three populations? I mean, patients in the waiting list, patients transplanted, and patients of the general population. What is your opinion? For example, we can start with Eric, Claudio, Juan Ignacio.
Yeah, thank you for the question. I think that there are good indications for focal therapy, and focal therapy, the indications are now that we explain are probably the patient with intermediate risk prostate cancer. So whatever the patient in the waiting list or already transplanted, I think that it doesn't change anything. And if we consider, because that what we say, we now have the MRI, and with the MRI and the targeted biopsy, and we have new tools in order to better characterize the lesion. And if we arrive to have a good characterization of the lesion, if we know exactly what to treat and where to treat, if we have the good energy sources, we can treat focally, and it's probably a very good option for this patient who have already comorbidities. So from my side, I think that it doesn't change anything, and of course the patient have the same expectancy, whatever the prostate cancer will not change.
What do you think, Claudio, about this? Do you think that we have to keep on the same criteria for all these people?
Thank you so much for the question. I think my opinion is very similar to Eric's opinion, because there is no clear. I think the main point is the immune environment of each patient. So the situation of the immune response, the immune environment of each patients, I think is different between the transplantation and after the transplantation. And when you have a relapse of a renal failure after a transplant, so but there are no data in this way. So I think in general we have to consider all at the same population. If you have a low risk or intermediate risk, you can be treated with focal therapy. We don't know still what happened with the immune response in these subgroups, but by the moment I think we can treat all of them.
Ignacio, your opinion?
Yeah, basically I agree with you, but I think probably I think all of us know that the management of prostate cancer, it's something that it's need to be very, very bespoke to every patient. And probably in this population is even more important. I think there are not two cases that are the same. So to individualize and to bespoke the treatment would be the ideal, because also we are considered, this population as a kidney transplant recipients, but also the age, the Gleason, the condition of the patients, many things, also the quality of life also could have an impact. But I think that for the reason that the transplant probably is not going to be the main criteria to drive one of other decisions. This is my idea.
I agree with you. I think that probably the question of the similarity of the results of the prognosis between the general population and the kidney transplant population make us to decide the same in low risk and medium risk prostate cancer in these patients. Maybe the effect of immunosuppressors could have some influence in high risk patients, and maybe our decisions in this population must be different. We have here a very interesting question. We have 3 minutes. Well, we can take 5 minutes plus. We have some questions from the audience. The first one is a very interesting question from Dr. Joseph Marenkak. He asked us that have we any data from focal therapy in patients with local progression after radical therapy for prostate cancer? I understand that he is asking about those patients who have been treated with radiotherapy and shows a progression. The question could be, do you think that we could use, for example, cryotherapy in those prostate relapse cancer patients transplanted after the radiotherapy? Do you think that we could apply the cryotherapy? I have my own opinion, but what is your opinion? For example, Claudio, imagine the patient is transplanted, he has already been treated with radiotherapy, and he shows a progression of PSA, and he shows a positive biopsy. Do you think that this patient could be treated with cryotherapy?
I think if you have a good mapping biopsy of this patient and is a pattern of relapse of an index lesion, which means the patient has relapsed in one lesion, and you have enough prostate volume to make a focal therapy, which is to treat the tumor with a safety margin, I think you can do it. I think can be dangerous if you do a whole gland therapy with cryotherapy in this type of patients. The risk of fistula, etc., will be higher. But if the patterns of the relapse is with one lesion, I think you can do it.
Great. According to for example, you know all that radiotherapy has shown some doubts about using kidney transplant patients, and Juan Ignacio has raised this question because of the secondary effects on the graft and on the ureter. Do you think that there is any energy better than the others when we compare cryotherapy, electroporation, HIFU, according to the spread of energy and the possibility of complications in the graft, in the ureter? Do you think that there is some evidence, or could be some evidence about some advantages of some of them? For example, Juan Ignacio, what do you think about?
I don't think so. I think it's probably, the majority of those tumors are less of thinking about to treat it focally. I think are far away from not far away, but not close to any related like a potential area, the kidney graft or the ureter, of everything. We are gonna basically treat the posterior tumors or apical. Probably in the anterior part, if you do a very, very extensive treating area, but I don't think so. I think if you have experience and you do a very good ultrasonographic evaluation, and you are using whatever software that can help you to guide the focal therapy, I think there is no reasonable risk to damage anything. I don't know what Eric, that also have a lot of experience on this, think about it, but I think it's very safe from this point of view.
Yeah, I don't have any experience of kidney transplant patient with cryotherapy and salvage cryotherapy, but for sure, I agree with you 100%. I would pay more attention to the rectum than to the ureter in this case, because there is no risk, because the ureter is far away. We can say that it's far away from the prostate. So doing a cryotherapy, salvage cryotherapy, I think is not a problem, and I would do it if I had a patient at the consultation with a recurrence after irradiation. I would offer him first intention, not surgery, not HIFU, not anything, cryo first.
Our last question comes from the audience. I think it's a very interesting question, and comes from a guy that we know, Juan Ignacio and Claudio, Giuseppe Maiolino. He is asking about the indication of focal treatment in those patients transplanted who could be, in the setting of general population, candidates to active surveillance. The question could be, if we have a kidney transplant patient with a low-grade tumor, and this case could be candidate to active surveillance without kidney transplant, do you think that we have to go ahead with the focal therapy or global therapy because he is transplanted, or we could get the risk of going through the active surveillance? What is your opinion about this? Eric, for example, what do you think?
Difficult to answer, and depends on the tumor size and
very difficult to answer.
Many criteria, but my first suggestion should be to continue the active surveillance, and maybe with I would say the PSA every 3 months, or maybe a shorter time in between the exam. But it's not
And it's something that some criticism that we had at the beginning with focal therapy is not because you have focal therapy that you have to do it. So especially in low risk patients. So, and we have to treat low risk, transplant patient like the other one. And would you do a radical prostatectomy? That the question. If not, you don't have to do any focal therapy.
Probably this is a very good message, a very good idea to take home before we end the webinar. Probably the patients must be treated according to the general rules, especially in the setting of low risk and medium risk. And the only variation could appear in the setting of high risk. Well, I think that we have reviewed this issue very well. I would like to thank you for your splendid presentations, for your outstanding. And I would like also to take advantage to congratulate Juan Ignacio, because he was yesterday named a member of the New York section of the American Urological Association, and he was presenting some results of the Jupiter protocol. So congratulations, Juan Ignacio, because it's important for you and for also the European urology. And well, if you don't have anything to tell us, thank you so much, and well, have a good time.
Thank you, Enrique. Thank you.
Thank you. Thank you very much. Bye-bye.